My name is Keith Pearce. I'm a consultant cardiac scientist based in the Cardiac Diagnostics unit up at Wythenshawe Hospital in Manchester. I've been asked to talk to you briefly about some of the issues facing cardiac diagnostic services during this pandemic and the effect that that has had on all of our departments. Whilst our department is a reasonably large tertiary unit, many of the core functions of the unit are exactly the same, irrespective of which department you work in across the UK. We know that departments function differently. We know that some have variable staff numbers, but the core investigations that we all undertake every day, whether they be echocardiography, ambulatory monitoring, autonomic function testing, exercise testing, implantable cardiac device surveillance, they are available in virtually every single unit. During the COVID pandemic, the diagnostic services have had to undertake some significant changes in the way that they deliver, and also they've had to undertake some significant changes throughout the different phases of the pandemic. This talk is going to concentrate predominantly on phase 2 and 3 of the pandemic, described as the catch-up phase and the future phase. What will services look like as we move forward? Every department will have had to have a period of suspension of activity, and catching that up is going to be incredibly difficult. However, how will we catch up this missed activity? There are lots of questions being raised about that. For example, are these investigations still required? Where do we begin? Who do we begin with? Do we look at the urgency of referral? Which investigations do we open first? How will we ensure social distancing is maintained even when we turn the tap back on for elective diagnostic testing? And we cannot simply fall back into the pre-pandemic situation of a stretched services where demand exceeds capacity. We are planning to open up 2 areas of diagnostic investigations during the phase 2 or the catch-up phase, and these are primarily ambulatory monitoring and echocardiography. We made a decision to identify referrals in patients below the age of 60, first of all, who were urgent referrals, and then we will move into the 60 to 80 year age bracket, and then into the 80 years plus. And there is no specific evidence as to why. It is just an attempt to shield the most elderly for as long as possible whilst trying to ensure we can get back to some form of normality. In order to open our doors, we've developed a robust SOP which outlines the entire process from the front door to coming into the unit and exiting the unit at a separate point. We've got some clear directives for social distancing, some clear pre-attendance information, and we've even got a meet and greet service where we are checking patients' temperatures, issuing any requirements for face masks or gloves that they may have whilst we escort them through the department. It's really important that patients have confidence in our ability to look after them and not just worry about coming to the hospital with the angst and the fear that they may be coming to somewhere where COVID exists and that they may be subjected to it. For our ambulatory monitoring, we have opened up a single examination room where we have got one of our trainees who's produced a video that outlines for the patient how they hook up the monitor, how they attach the monitor, and how they set the system off recording. We have a facility for troubleshooting that immediately afterwards, where the patients can come out and seek advice, but predominantly this is a self-led, patient-led initiative where they will fit the device themselves and they will go home and they will bring the device back. This is to ensure compliance and to ensure that we get some accurate recordings and not any wasted slots. Within echocardiography, we again are trying to stick to social distancing as much as possible, and we've opened up our activity from 8 AM till 6 PM. We've opened up 2 rooms that are very separate to each other. We're offering 1-hour appointments for the patients to ensure there's adequate time for the patients to be examined, the staff to clean the equipment, to do a report, and to have full preparedness and readiness for the next patient who's due to arrive. These simple changes are a start as a plan for us to begin and open up the concept of diagnostic elective activity. The next phase is the future phase. What will happen in redesign? How will we deliver services differently to how we delivered them before? And there's no doubt that the users of diagnostic services will change their practice, which may mean that we have to change our practice. We've seen the introduction of telephone consultations. This has had a major positive effect and supports a realisation amongst many of my clinical staff colleagues that an overutilisation of cardiac diagnostic testing before may have been evident. However, we still need to be able to flex and change. We're looking at ways to ensure patients who are seen in a face-to-face consultation, where possible, have direct access to the diagnostic tests that they may require, a one-stop or a true one-stop visit. For patients whom telephone consultation has been completed and they still require diagnostic investigations, then we've got to look at services where there is no bed stock. The concepts of primary care centres or diagnostic hubs may become the norm. Places where patients can attend for a diagnostic test will happen where there are no A&E departments, where there are no hospital beds, and patients will gain confidence in coming to a centre for a test and going home. I think it's really, really important that this is a real opportunity to fit in with some of the plans in the NHS long-term plan. And I think that we as units and departments want to ensure the quality and the clinical governance is embedded and maintained in these areas, these hubs where we could provide services. I think the realisation that doing things differently could actually provide staff an opportunity for different working hours, different working patterns, days, and even improve the work-life balance for many of our diagnostic staff. The necessity for patients all to attend the hospital for an investigation has been proven that it's not required, and that if you work clever, you can in fact deliver those services in a different way. Just like many other departments, we have lots of conversations internally about if we could redesign this service, we wouldn't have done it this way. And I think now is the perfect time to redesign those services. The promotion of digital innovations, for example in cardiac device management, they are a must. Review the working patterns and review the places where services are delivered. And if it isn't broken, then you may not need to change it. And I expect many departments may want to change it and have never had the opportunity to change it. And now is the time to challenge this. I hope that some of these questions and some of these comments will raise some internal debates within your own services. And please don't hesitate to make contact through the BCS if we can help in any way. I wish you all the very best. Please keep well, and thanks for listening.